Hey, future nurses, NCLEX-bay is officially back. So if you're writing your exam this June, you gotta wake up right now because pediatric medication administration rules are extremely high yield, and you know the examiners absolutely love to trick you on this. Let's master this blueprint together. Today's high-yield explainer is broken down into 4 quick parts: oral med guidelines, parenteral and IV rules, pediatric math, and finally, a 5-minute quiz protocol to test your recall. Let's dive right in.
All right, kicking things off with Section 1, Oral Medication Guidelines.
So, when we're dealing with pediatrics, structural handling is literally critical to ensure complete dosing. As you'll see here, there's a whole variety of acceptable measuring devices. Now, because little ones usually can't swallow tablets, most meds are going to be liquids or suspensions. But here is the classic trick. Suspensions settle to the bottom between uses. You absolutely must mix them thoroughly right before pouring, and always choose the correct, precise plastic syringe, dropper, or cup based on the kiddo's developmental age. Okay, moving on to physical positioning. This is huge. Never lay them flat, always sit the child upright with their head elevated. Now, if you've got an infant who's fighting a really bad tasting med, you want to follow these exact lap placement steps. You place the little one sideways on your lap, tuck their closest arm firmly behind your back, cradle their head, hold their free hand, and listen. This is a massive NCLEX point right here. Place the syringe in the side and toward the back of the mouth. You push it slowly. This prevents spitting and, more importantly, dangerous aspiration. All right, here are your absolute NCLEX pro tips for oral meds. Never ever mix medications with basic necessities. I'm talking formula, milk, or baby food. Why? Well, it creates a super unpleasant taste association, meaning they might just refuse their food later on. Plus, if they don't finish eating the whole thing, they get an incomplete dose. No way we can risk that. Now, if a med tastes totally awful, pinching the nose and using a straw is actually completely acceptable for older kids. And it's a great idea to offer a frozen juice bar right after swallowing to clear out that nasty taste. Moving on to Section 2, Parenteral and IV Administration Rules. Listen up, because knowing your absolute clinical limits here is quite literally the difference between passing and failing. You absolutely must memorize this. For intramuscular injections in neonates and infants, the vastus lateralis is your go-to preferred site, and it is strictly capped at a volume of 0.5 to 1 milliliter. Look really closely at the other muscle groups here. The deltoid and ventrogluteal, absolutely not safe for neonates and infants. Choosing those sites on the exam is a massive safety violation. Now, locating that vastus lateralis site on the anterior thigh takes real precision. When you're using this site on your pediatric clients, you need to make sure your needle parameters are precisely 1/2 to 1 inch long using a 22 to 25 gauge needle. And remember, you're calculating these dosages to the nearest hundredth and measuring them out with a tuberculin syringe to guarantee absolute accuracy. Let's pivot to IV rules. And you guys, this is highly critical. When you're giving intermittent IV medications, that 3 to 20 milliliter normal saline flush, it has to be carefully included in the child's 24-hour fluid intake. Pediatric clients are so vulnerable to fluid overload, so we've got to watch this like a hawk to prevent life-threatening overhydration. Also, keep in mind that we usually use special microdrip sets like Burats for medication prep. These are perfectly calibrated to deliver exactly 60 drops per milliliter. All right, shifting gears to Section 3, Pediatric Calculation Methods. Please do not let the math intimidate you. It's all about just following established protocols, like the West nomogram for estimating body surface area, or BSA. I know it looks a little complex at first glance, but in practice, it's a breeze. You just find the child's height over on the left column, find their weight on the right column, and literally draw a straight line connecting the two. Right where that straight edge crosses the middle surface area column, boom, that gives you their precise BSA in square meters. So, what exactly do you do when you only have an adult dosage recommendation to work with? You use this exact formula. You take the child's BSA in square meters, divide it by the standardized adult BSA, which, remember, is always 1.73 square meters, and then you just multiply that number by the adult dose. It's really that simple. That formula is going to give you the safe, precise child's dose every single time. Okay, bringing it home with Section 4, the final 5-minute quiz protocol. Let's see if your brain is fully back in the game. I'm going to read the question and the 4 options, and then I'll give you a few seconds to think. Do not pause this explainer. I want you to test your real-time thinking right now. Question 1. A parent plans to mix an unpleasant tasting medication into their infant's regular formula.
What is the priority nursing response? A, approve the plan. B, advise adding sugar. C, instruct not to mix with formula. Or D, suggest mixing with cereal. What do you think?
Time's up. The correct answer is C. You must instruct them not to mix it with formula. Never mix meds with basic necessities, like formula or baby food. The whole rationale here is that it creates horrible taste associations, meaning the kid might just completely refuse their food later. And even worse, if they don't drink the whole bottle, they're getting a dangerous, incomplete medication dose. Makes sense, right?
All right, question 2. Which intramuscular injection site and volume limit is safe for a 6-month-old infant? A, deltoid, 1 milliliter. B, ventrogluteal, 0.5 milliliter. C, vastus lateralis, 0.5 milliliter. Or D, rectus femoris, 1.5 milliliter. Lock in your answer.
And the answer is C. Based on our strict safety parameters, the vastus lateralis is the preferred and honestly the only truly safe muscle group for infants, strictly capped at 0.5 to 1 milliliter. If you chose the deltoid or ventrogluteal here, that represents a major clinical failure since they are explicitly documented as totally unsafe for this age.
Moving right along, question 3. When administering intermittent IV medications, why must the nurse accurately monitor the 3 to 20 ml saline flush volume? Is it A, to build a patient, B, to prevent pediatric overhydration, C, to maintain vein patency only, or D, to dilute the medication?
Got your answer? The correct choice is B. Pediatric clients are extremely vulnerable to fluid overload. The clinical rationale absolutely requires that the 3 to 20 milliliter flush volume be explicitly included in the 24-hour fluid intake metric. We do this to carefully monitor and prevent life-threatening overhydration. Ignoring even that tiny flush volume can be totally disastrous for a little infant.
Here we go, question 4. How should a nurse position an oral syringe to safely administer a bad-tasting medication to a resisting infant? A, directly down the throat, B, side and back of the mouth, C, under the tongue, or D, front of the lips? The correct answer is B. Pushing the medication straight down the throat is a huge no-no. It triggers choking and aspiration. Delivering the liquid slowly to the side and toward the back of the infant's mouth minimizes its contact with the taste buds and ensures safe swallowing, even if they're putting up a fight. Last one, question 5. Let's do some math. A child has a body surface area of 0.86 square meters. The average adult dose of a medication is 250 milligrams. What is the calculated child's dose? A, 124.28 milligrams, B, 500 milligrams, C, 100 milligrams, or D, 215 milligrams? And the final answer is A. Let's break down the math using our formula. You divide the child's BSA of 0.86 by the standard adult BSA of 1.73. Then you take that result and multiply it by the adult dose of 250 milligrams. That leaves you with a very safe, calculated dose of exactly 124.28 milligrams. So, how did you do on this pediatric comeback challenge? Drop your score in the comments below. Did you get a perfect 5 out of 5? Be sure to share this explanator with your nursing study group, save it for your final June review, and follow NCLEX-bay for more. But before you go, I want you to ask yourself, if a simple 3 milliliter flush can dictate life or death for an infant, what other tiny details are hiding in your adult med-surg chapters? We'll uncover all of those in our next system masterclass. See you there.